I come about every 6 months or so, and I give a lecture on PTSD and pain here. And so, I know David and Jim and others in the room maybe have heard a bulk of this, but I try to entice you all, even for those that have heard it before, with some new information as I go back and look at the literature each time and try to add in some extra information. But I think in general the goal here is to give you guys some nice information about what is PTSD, how does it relate to pain, and what are some things in primary care you guys can do right out of the gate to potentially identify and do something about post-traumatic stress that you might be experiencing with your patients. So I'm assuming I can just hit the arrow here and get mine going. Perfect. All right. So PTSD for the PCP is what we call this. So it's really about, again, how to diagnose it, identify it in your practice, and then some behavioral, what I call behavioral how-tos, just some tips for things that you personally can do with these patients as you're seeing them as well. So, the place I always like to start with PTSD is defining what a traumatic event is, because post-traumatic stress disorder hinges obviously on a trauma. There has been some change in the definition for the DSM-5 for what a traumatic event needs to be. And so a patient has to actually experience, witness, learn about, or have repeated exposure to these three things that you see here. So actual or threatened death, serious injury, or sexual violence. The main issue with the traumatic event is it's very individual to how the person is emotionally experiencing that traumatic event. So many of us can go through, for example, learning about various traumas and not have an intense emotional reaction, but some can have incredibly intense emotional reactions. So it's less judging what the traumatic event itself was and more judging what the patient's reported experience is of that traumatic event. So if it was, horribly catastrophic for them, then you want to think about that as meeting that index criteria. So when you're diagnosing PTSD after a trauma like that occurs, you need to see symptoms of post-traumatic stress, and I'll go over what those are, happening for greater than 1 month. And there has to be significant distress with the patient or impairment happening from that post-traumatic stress. So there's really these 5 different categories of symptoms that you're going to be looking at with a full-blown PTSD diagnosis. So the first I've explained, which is exposure to a trauma. The second one here is re-experiencing symptoms, and so those can come in various forms, and they only need to have one of these, and so that it can either be memories that are intrusive and come back to them uninvited. It could be dreams and nightmares that spontaneously are occurring, and those don't have to be nightly. They can just be frequent. Flashbacks to the traumatic event where they feel like they're reliving it. And then these other two are physiological or psychological responses, basically, to reminders. So, if it was a trauma related to a car and they see a car and then they have an intense reaction, it might not be the memory flashing back, but if their whole autonomic system is arousing intensely, that would qualify. The second cluster of symptoms are related to avoidance. So you can imagine if you're re-experiencing this stuff, you don't want to, right? So you're going to try to avoid these things. And you want to see this avoidance happening, and you only need one of these, either by the patient avoiding memories, thoughts, or feelings about the traumatic event, avoiding any external reminders, and those things are doing certain activities or going to certain places, people, conversations, etc. So you need to see a very clear avoidance out of here to meet full criteria. Hyperarousal, so you can imagine if you got re-experiencing happening and you're trying to avoid it, you're feeling pretty intense about it. That's the hyperarousal piece where our sympathetic system is massively turned on. And so you can see you need 2 of these symptoms here. And that can come in the form of just intense irritability and anger outbursts, where people just feel like their short fuse is really, really short. We've added in the DSM-5 reckless and self-destructive behavior as a pattern. So it may be that the patient doesn't recognize the irritability and anger, for example, but behaviorally it may come out as reckless or self-destructive behavior. They will have an intense sense of hypervigilance, a really increased startle reflect. They'll be that person that jumps if the book falls on the floor behind them through the roof. Their concentration is often very impacted, and that overlaps with depression symptoms. Sleep difficulties, typically difficulty falling asleep, or again the nightmares kind of coming up. A new category in the DSM-5 that's been split out as separate now are these cognitions and mood issues, and you need 2 of these symptoms. And some of these were in the old DSM, and been regrouped into this category, and some have been added in here. And so the list is you need two of these. You can have some kind of memory loss during the actual traumatic event. It's really a form of dissociation that might happen that's unexplained by a traumatic brain injury or some other cause for why they don't remember it, but they went through it, but they simply just can't remember portions of it. They can have pervasive sort of negative beliefs about the world, about everything going on around them. That's a new criteria. They can have intense thoughts around self-blame. Everything's my fault. I cause everything, especially when you're in pain. I'm destroying my family because I can't do anything. Intense negative emotions, anhedonia, again, overlapping with depression. Detachment is really about having some interactions with people but feeling like they can't connect like they used to. So even though that person's there, it could be a loved one, could be a friend, and they just don't feel like there is that connection happening. And then also an absence of positive emotions going away. All right, so let's talk some about what causes PTSD. I think there's a thought by a lot of patients who have PTSD that going through trauma will result in that. But the reality is actually 70 to 90% of us, if you look at some of these large population-based studies like the NCSR, have shown that 70 to 90% of us have experienced what we would call that criteria A, traumatic experience. And so the vast majority of people, however, don't get PTSD. So the reality is we're generally pretty resilient to trauma. It's really normal to experience a lot of the symptoms I just talked about for the first handful of months after a trauma, or several weeks even, and then that dissipates and we move on. With PTSD, we think of it as getting stuck in that post-traumatic stress process that all of us kind of normally go through right after a major trauma, but resolve. So you can see, lifetime prevalence tends to be close to 7%. You see huge gender differences, so women are much higher at risk than men. And in some of the studies, they've tried to look at rural versus urban kinds of differences, and there really aren't any that we've seen so far. I want to mention vets as a special population. I know many of you treat vets out in the community. And so there's been an increase in the amount of trauma that our vets are experiencing as these wars progress in history and time. And so you'll see the rates actually increasing also in PTSD with the burden of trauma is sort of the vulnerable factor that we talk about. Moving kind of towards PTSD and pain, you'll see that there's huge overlap. So, in looking at a bunch of different studies, whether you look at folks who have PTSD, how many of them have chronic pain, or you look at folks who have chronic pain and see how many have PTSD, you'll see a variable rates of overlap, but it's pretty high, 35 to 50% prevalence overlap. So if you have a chronic pain patient and you're seeing something that sniffs and smells like anxiety, you want to be thinking about whether or not PTSD is a factor. In looking at what some of the studies have told us, there's about a 7 to 8% overlap in these two issues in general. The rates are tending to be higher in some ethnic minority groups. There's been a Detroit study that looked at African American populations. There's been some Native American studies as well that have shown increased rates. Part of that is due to predictors that we know are an issue, like violence-related trauma results in higher rates of PTSD, for example. Severity of injury increases potential for PTSD. And you see, often folks with lower socioeconomic status are involved in more violent traumas for various reasons. You'll also see, again, if you look at a PTSD cohort, the overlap, depending on which study you look at, is anywhere from 20 to 80%. And I'd say even if it's as low as 20 is pretty high. So again, you want to be looking for that overlap. And I guess vice versa, if you have a PTSD patient, be asking about pain. In the pain cohort, in the other direction, the numbers tend to be a little bit lower, but still, again, from 7 to 50%. We also know that, the higher the pain, there's more affective distress and more disability. So these things just go hand in hand, which makes total sense to us, right? It's very face valid. There's some research coming out now that's starting to look at neurobiological overlaps about what might improve treatment with this. If we have a really turned on sympathetic system and anxiety is way up through the roof, are there ways that neurobiologically explain why PTSD and pain go hand in hand, and vice versa? Can we treat the two of them hand in hand as well? But there's a lot to be done there to kind of figure out what's going on physiologically in people. Negative beliefs about self-mediated pain. negative beliefs about the self, I guess what I should say is mediate pain interference. So meaning, if you have a lot of negative beliefs about your own self, you're going to tend to have higher pain interference, and that's why when we can treat those negative beliefs psychologically, you'll see pain interference start to clear up to some degree for folks. All right. There's also been some studies that have looked at improving PTSD and chronic pain, and what you notice, by and large, is they tend to get better together and they tend to get worse together. So you want to think about that in terms of if you're able to do a successful treatment for folks in either direction, you're probably going to be impacting the other issue. Okay. A couple of recent things, and this is my sort of tidbits for those who've heard this before on some level. There's a few new studies out I thought worth mentioning. There's a new one looking at a cohort of people with mild traumatic brain injury, and they're finding for those folks who have PTSD, they actually have worse chronic or more intense worsening headache pain. They're starting to hypothesize is there something again going on physiologically in the brain with that traumatic brain injury that's causing more headache. But again, it's an increased risk factor if you've got PTSD with that pain. In a vet population, we're also finding that your current level of pain severity is also associated with having more PTSD, a higher severity of PTSD symptoms, particularly those re-experiencing symptoms that I mentioned before, as well as having bad sleep and increased alcohol use. So I think these are things that we know, but these studies are continuing to show these kind of trends in the population. And then there's an interesting study that looked at a couple of different pieces of PTSD. So, and I'm going to talk a little bit to you about dissociation, with this idea of sort of leaving yourself when not being so present in the moment. And that's actually associated with a delayed response in pain threshold. But on the flip side, if you have increased anxiety in general because you have PTSD, you have an intensification of chronic pain. So there's this like paradoxical way that PTSD is actually impacting chronic pain. And I'll give you a couple case examples where you can see that dissociation makes it harder sometimes for us to recognize someone having PTSD that needs to get treated versus somebody who maybe isn't dissociating or is more intensified is coming in and complaining much higher of chronic pain. So basically, bottom line, there's a lot we don't understand quite yet. We're working on it. All right. So in terms of what can you guys do, getting to the practical part of this talk, one of the first things I recommend massively is to screen for it. This is really easy to do. The VA has put together these 4 screening questions and validated this very nicely. They're yes or no questions. You guys can easily either memorize these or hand them out when you're screening for depression or other things with your patients. We do this regularly in our clinic and wind up picking up a lot of hidden PTSD cases with it. The way this works is if you answer yes to 3 or 4 out of 4 of these questions, there's a very high correlation of a diagnosis with PTSD. So you want to think about whether or not you want to do some more in-depth assessment of that if someone comes out positive on this screener. The other thing I recommend is, when you're working with someone with PTSD, is measuring their symptoms. There's a great post-traumatic checklist that maps right onto the DSM criteria. The VA offers all of these things on their website where you can print this out and use this as a questionnaire. You want to think of this as your blood test, so to speak, for treating PTSD. So if you're treating with medications, if you're trying to get folks engaged in behavioral care, you want to take kind of a litmus on this to see where their post-traumatic stress is at. The other thing that we talk, and I'm sure a lot in this group about as well, is just measuring pain interference. And so understanding whether or not pain is actually getting in the way of function as well is another piece you guys can measure regularly that helps you kind of judge whether or not treatment needs to be stepped up. Speaking of stepping up, so the approach you want to think about, first of all, starts with engagement. And these patients are particularly hard to engage because they've got intense anxiety, they've got trust issues, their filters are not quite right, so they might be more abrasive than other patients. So you want to think about, first of all, do you have decent engagement? And as you do that, that really comes before you can do any real assessment. People aren't going to tell you about their histories very well if they don't feel very engaged. And then, of course, there's medication, things that you guys can do in primary care. So being able to treat some of the core symptoms of PTSD can really help folks take the notch down on some of those intense symptoms and help them get more behaviorally engaged in the treatments that are going to give them an even bigger jump. Then in terms of brief interventions you guys could potentially think about doing, there's two that I'll talk a little more about. One is grounding and one is behavioral activation. And then finally, the biggest step up is, and then if you're doing all these things and the patient still doesn't seem to be getting better, trying to refer to more intensive psychotherapy. And then along the way, measure, right? Again, that's where that PCL comes in, where you can measure the symptoms to see how they're doing, to judge whether or not you want to step up care. So psychopharmacology, just, a couple of comments about that. In the VA population, there's a new study that just came out that showed there's a much higher rate of co-delivery, I guess, of benzodiazepines in conjunction with chronic opioid therapy for vets who are in chronic pain and have PTSD. So, benzodiazepines are something I see really frequently in a lot of my patients, despite the fact that they're on opiates as well. And so one recommendation I always have for my patients is take it in a scheduled way. For you guys, using long-acting benzodiazepines as opposed to the shorter-acting versions is much better because the patient gets a less of that subjective kind of reinforcing hit. And it's also easier for them to schedule that medication instead of taking it at the peak of anxiety, which can make their anxiety worse over time. And then thinking about kind of ways to treat the core symptoms again, SSRIs, SNRIs, et cetera. And measure, always measure along the way. All right. So, when we're thinking about behavioral kinds of interventions, the way that we explain this to patients is we talk about the fact that anxiety is like this triangle here of these three circles that cycle back and forth to increase anxiety. And we map the behavioral interventions right on to those three circles. So you've got the body itself that gets very anxious physiologically, and this is often the easiest for patients to recognize. Their heart racing, getting short of breath, sweating, flushing, etc. When they get anxious, they also tend to have their brain get anxious in terms of their thoughts. So they start to think really catastrophic things that are going to happen, things not being safe, etc. When this happens and that starts to really stir up, what you want to do is you want to seek safety, right? If you get anxious, you want to go and be safe. And so what they tend to do is get involved in a pattern of avoidance behaviors that ultimately aren't very helpful for them long term, right? Like I can't go to the grocery store anymore because there's too many people there and it just stresses me out and I can't tolerate it. But then you can't get your groceries done or get out and do what you need to do. So on the left-hand side with this black line I have down the screen are what we call management strategies for anxiety. These are all things that basically help treat symptoms of anxiety, but they don't actually treat the core problem. So medications are in that vein. They help the symptoms reduce some. Teaching people relaxation strategies can help people bring down their body symptoms that come up. Learning cognitive strategies to challenge these thoughts. I like to say, all those strategies combined can help people about 30% with their anxiety, which is significant, but it's not enough. Okay, so that's often anxiety is very debilitating for people, and 30% might help in the moment for certain things, like me giving a lecture and saying, talk slowly, take a deep breath, right? And I can get through the lecture, but it's not going to cure my fear of giving lectures, right? The cure for me is giving lots of them. So I've done lots and lots of them. I'm less afraid of them. That's the exposure side, right? So the more you do an activity, the more your brain learns that activity doesn't need to be feared anymore, and that really actually is what we call treatment for anxiety. Okay, along those veins, I promised I'd talk to you a little bit about dissociation. So with dissociation, what you see happen with patients is they sort of leave themselves. And if you ask a patient with PTSD and I say, do you ever notice you're sort of outside of yourself, kind of watching what's going on, but you don't feel like you're really present? And they'll say, yeah, absolutely. That happens to me actually all the time. You might notice this happening when you're in a medical appointment. This might happen with a patient when you're explaining instructions to them and they seem like they're listening and they're nodding and saying yes, but then they're really not taking in anything that's there. This is really not good for the patient, right? This is dangerous for them at this point and dysfunctional because they're not present in their life in that moment, but it is a conditioned response that they've learned from the trauma, and during the trauma it was a very safe thing to do. Their brain knew this was dangerous, they needed to leave. This is very common for people that have been abused as children, childhood sexual abuse, to learn that just natural dissociation, the brain saying, get me out of here, this isn't safe, but I can't get my body out of here. There's also physiological effects. It actually has been shown to shut down immune functioning in patients as well. It makes them more vulnerable to disease, infection, etc. So talking to patients about that to help them recognize that's what that is, to help them recognize that goes with PTSD, and then to let them know that you can actually teach them grounding skills to stop it. There's no pill that we have that treats dissociation, but there's a behavioral thing you can do, in less than a minute that actually pulls you right back into the moment. And it doesn't take very long to break that habit of dissociation if you've got a patient willing to give this a try. So that's why I say what you guys can do is you can educate and then you can teach the skill. And the idea is you cue people to their physical environment, right? So you can ask them to go ahead and notice 5 things that they might hear, see, feel, or smell. And you can ask them to do it right there in that moment and have them notice how that just physically makes them come right back into their own body when they might have stepped away. And they can train themselves to do this, and even in a social conversation, if they notice themselves leave, to come back and stay. And so when they're coming back and staying, that's also like a little mini exposure, right? Because they're not actually doing that avoidance thing and leaving the conversation. They're actually pushing themselves to stay. So that's an incredibly handy one that we do before we do any more deeper kind of trauma-focused cognitive behavior therapy. If we've got a lot of dissociation, we need to keep people present with us in the moment in therapy. So this is a skill we'll start with oftentimes. Behavioral activation is a term for a cognitive behavior therapy that's really about targeting people's specific behaviors to get them more active. Sometimes there's this misconception that means go have somebody go for a walk. Now, that's not to say that going for a walk isn't a potential behavioral activation target, but in this psychological treatment, which really originally was developed for depression but now has been tested to some degree with people with PTSD as well, is really about targeting specific behaviors that are going to increase people's mastery or pleasure in the world and decrease their avoidance that's kind of keeping them stuck in that cycle of depression. So, avoidance again, right? It's going to limit functionality, it's going to reinforce their anxiety, and it's going to increase pain interference. So what we want to do is get them to become more active. So we need to kind of unlearn that fear and target functionality. And what you'll notice with people with chronic pain in behavioral activation is that folks don't want to get up and do anything because it's going to hurt. And so confronting that and saying, so, if you were to get up and do more activity, is that going to hurt you right away? And you really want to avoid that, right? And so you want to sort of normalize that and say, yeah, there are really good reasons you stay lying down. But the problem is that longer term, then you're doing less and less over time. And so, really, let's see if we can just get you up doing just a little bit. What if you just got up, and walked to the other room and then went and laid back down? Starting with the really, really small targets that are not going to cure this person's depression, but are going to be something they can succeed at right away is a really great thing. With PTSD, for example, if someone had a car accident and they're afraid of cars and they're getting agoraphobic, they can't see the cars outside. You might start small and say, can you look at a picture of a car while you're on your couch for a few seconds and just kind of tolerate that, and then move that up where maybe you go to your window and look at the car outside and then leave, right? So you want to break things down into really small ways to get people moving on some level, but also acknowledge that it's hard for them. There's real reasons why it's reinforcing for them not to move. Okay. A couple of patients, just to give you kind of a flavor of how this can look in clinic. We had a patient, I call this the angry patient example. I'm sure you've all experienced that, where you've had a patient get a bit explosive or angry, and you're sort of going, whoa, what happened here? So we had a 54-year-old male patient come in who had a history himself of being a victim of domestic violence and sexual abuse as a child. Turns out on his post-traumatic checklist, he was up in the severe range at 69, although he hadn't been measured for that until he came to see me. He had a history of post-surgical left sciatica, and mainly he was on nortriptyline. He had gotten off of the opiate roller coaster, thankfully, but medication-wise, things were very simple, but not really making much of a dent. He was also not coming in real frequently, and this is a pattern you'll see with PTSD folks. They're really avoidant. Oftentimes, they don't want to come in necessarily because they know they're going to have to confront the things that they're trying to avoid. He was actually refusing medication interventions as well, just was very reluctant to want to take any other medications. And he was getting angry. The providers in the clinic were letting me know that it was very frustrating for them. They felt like they were getting attacked by this patient and really didn't understand why. And so, one of the things I want to give you as a tip, again, going back to that stepped care approach, engagement is key. And so when you've got a really angry person, sometimes it's not worth plowing through the rest of that visit, trying to get to that end game of what your whole treatment plan is, and take those couple of minutes you have left to really just listen and reflect what you're hearing. And sometimes just calling that out in the moment and saying, you sound like you're just incredibly angry at me right now. and just being silent and seeing what they do with that. It often, can de-escalate in the moment, and let patients kind of say what they need to say. Who, and their agenda may be less bent on give me the answer, and it might be that you say, I need you to come back and see me because we're out of time, and you're really angry right now, and I think it'd be good for us to talk when you're calmer, right? But in the back of your mind, I want you thinking about, gosh, this patient gets angry a lot really easily. Think about PTSD, and then you might want to screen for it if you haven't already with those 4 questions. Then you have the patient who says they're fine, like this woman did. Everything's fine, but you notice nothing is getting better. And again, this is that paradoxical piece that I was talking earlier about PTSD, that now we actually have a study looking at that, where you've got a lot of dissociation happening, and sometimes that makes it seem like everything's fine. The patient's dissociating or kind of appearing more competent than they are. So with this woman, we had a 60-year-old woman. She was Caucasian female, who had childhood sexual abuse. And when we actually gave her the post-traumatic checklist, she was also up in the severe category above 60. She had a long-standing history of back pain, and a history of discectomy. She was on hydrocodone, chronic opioid therapy, bupropion, duloxetine. When she'd come in and say, everything's great, and then the next visit, no, everything's horrible, and then the next visit, no, everything turned out fine, it's okay. And there was a lot of this back and forth with her doctor around, why do I need to talk to somebody else? What's that going to be about? So this is also an engagement thing, where you guys are in a position to be referring these patients, and it takes some time for folks to understand why this would be useful, why you think it would be, and sometimes saying, hey, can you just go talk to them and see what's going on, and then come back and tell me how it went. Over time, not giving up, this might be an issue. Turns out, the doctor that sent this patient to me didn't know this person had PTSD, and I screened her, and sure enough, she had actually severe symptoms of it going on. So, thinking about what might this person be avoiding, if they're kind of coming back, but nothing seems to be getting better. Look for sort of subdued reactions, I call them, to sort of really bad events. If the music doesn't match the words, right? If they're telling you this story that's really horrible, but they're telling you this very kind of monotone, oh yeah, it's okay, yeah, no, I know it is really bad, but they're not having that reaction. Sometimes that's that numbing piece that comes with PTSD. So it's really different than the presentation of the angry patient who's, their fuse is blown up. And then again, the negative beliefs about the self really come into play here. Are they always kind of blaming themselves and thinking about themselves? Okay, evidence-based treatment and stepping up that ladder, right? When you're referring out, CBT therapies, the 2 top that we know of right now are prolonged exposure and cognitive processing therapy. The Institute of Medicine did a big review of these, and these are the 2 that came out on top. The entire VA system has now rolled these treatments out across the country. I also want to mention EMDR because it's a lot more available to a lot of people out in the communities. Eye movement desensitization treatment. There is some good evidence base. It's not as strong as the evidence base for PE and CPT, but the main component that really makes these treatments work is the exposure part. So remember that graphic I showed you with the line down the middle. It's really about having people approach the kinds of things they're avoiding so their brain gets a chance to lay down new memory that's going to combat that conditioned response to fear. A couple of cautions when you're doing referring out, is you can educate patients about this. There are some iatrogenic dangers to psychotherapy. They mainly involve having people do exposure with no kind of coping or avoidance prevention strategies. In other words, you go do exposure and it just gets worse because then you put that scary spider on them and they run out of the room screaming. That's just going to reinforce people's anxiety. So you have to have this kind of treatment really help people stay in that moment until that anxiety cuts down. Repressed memories is not as popular today as it used to be, 10, 20 years ago, but there's sort of these regression therapies. Let's go back and see if we can discover those memories. There's a lot of evidence, actually, that that's pretty damaging for patients to do, and memory is very flawed. As far as I know, there's no scientific evidence that repressed memories are actually a reality. And that goes along with the sort of exploring the past kinds of therapy. Requirements-wise, the kind of things you want to see people be able to do is, they obviously need to be able to attend sessions somehow, whether it's telemedicine or getting to those appointments. Usually these treatments are between 10 and 12 sessions long, best done kind of weekly. So do they have the ability to go to some kind of a treatment like that? Do they have adequate social support? Because doing exposure kinds of treatments make your anxiety worse at first. And so do they have that stability in their life to be able to have their symptoms get a little worse first before they get better? do you have a provider, right? And, is there good mental status? Because the reason is, this stuff really works because you're laying down new memory. If you don't have the ability to lay down new memory, the traumatic brain injury example for, that might cause issues with that, marijuana use that might impact short-term memory, high use of benzodiazepines, et cetera, those are all going to be contraindicated. It doesn't mean that people can't succeed at this treatment if they have those kinds of issues, but just knowing that that's going to impede because it's going to take longer to lay down those memories. I always like to end with there's an app for that, and so we're growing and growing in mobile technologies. The one I'd recommend the most is this PTSD Coach app. The VA puts this out. It helps people manage their symptoms of PTSD right on their phones. It's got some nice relaxation techniques in it. It actually has the screener built right into it. So if you have a patient using this app, they can screen themselves for their symptoms and tell you how it's been going for them over time as well. It helps connect with social media on their phones or contacts if they're feeling a crisis. It can help them dial automatically somebody that they want to configure in there. I've had some good experiences anecdotally with patients using this and liking it. Then there are a couple of coach apps, and these are really more for the psychotherapist delivering the treatment and the patients in the treatment to be able to do a lot of the homework that's prescribed, but have their phone kind of help them along the way. And I found a lot of patients who are more tech savvy really appreciate having that easy accessibility. It kind of normalizes doing the homework in your daily life, so you don't look weird with worksheets and writing things down, but you can just kind of discreetly do things on your phone as well. And then last, I'll end with, here's some resources I'll leave up on the screen, and then I think we might have, I know there's one question up on the board so far.
Great.
So jump to questions.
Yeah, great. Thanks.
Kari, I've got a question.
Yeah.
If among people who, it's a chronic pain group, and they have PTSD, do you have any data on how often the PTSD is interwoven with the onset of the pain? Like a motor vehicle accident where somebody died and the person had a neck injury or something like that, as opposed to the PTSD is sexual abuse when they were, children.
Right. There is some data. I don't have an exact number for you, but we've done some data at Harborview, which is our regional trauma center, and here in Seattle, across the 5-state area. And so when we look at people, we pulled them off the surgical wards and said, how many of you are coming in who didn't have PTSD prior and now have it after this injury? Right. The majority of people with PTSD coming in injured had it before or had several pre-existing. In fact, the average was like 4 to 5 pre-existing traumas before they got that severely injured in the hospital. So we've been able to look at it from that perspective. But we know, again, like the vulnerabilities for it are burden of trauma. So the more times you're traumatized, you might not develop it at first, but over time you will develop it. And you may do well and the symptoms get better, but then you experience another trauma and then it exacerbates and they come back as well. Yeah, so not the exact answer, but
Actually,
in the ballpark. Yeah,
it's a good question, and we got some research to do. So, Catherine Henderson asks, "What is EMDR again?" So, it's actually you met the time request, but
right.
for me, but you went through it pretty quickly, and it's worth hearing again.
So eye movement desensitization, I don't remember what the R stands for, but therapy, is a treatment that has become very popular because there are certification programs out in the communities that therapists can go and take, and then they can kind of hang that on their sign as community practitioners and say, I'm a trauma therapist, I use EMDR. So they've been really successful in disseminating that treatment to many practitioners out in the community. What it is I don't do that treatment per se, so with that caveat, but what I know about it is there is technique used to have people focus visually on particular places that the therapist asks them to while they have the patient actually exposed to some of these very intense emotions that they find pretty intolerable. And so when they've done some dissecting studies to see what's the active component of EMDR, is there anything with this eye movement piece of it, all those trials have been pretty negative, that there's nothing to do with kind of the visual. It's more of a technique to help people stay in the moment with the intense emotions, which does meet the definition of exposure. So I've had lots of patients who have benefited from that. I've had patients who have come in and benefited from that and then done one of these other treatments with me that I mentioned, the cognitive processing therapy, and benefited even more. So it's not that these things need to be mutually exclusive or take the place of another. It's more about, getting patients. Any of these things would be great.
Great. So Deborah Doms, and I want to do a follow-up on her question, but we'll start. Do you need to be in the VA system to access these apps?
It's a great question. Nope, they are completely publicly available and free on both iOS and Android.
Yes, free. They were developed by the VA. Public dollars went into it, and they are therefore open to the public access. Actually, we share a woman who we identified early with our pain tracker screener. She was highly distressed, has rheumatoid arthritis, early life trauma, identified PTSD. I went to it right away. She nicknamed me the Pain Whisperer over that, which I kind of like the name of it because it elevates my status, at least in someone's mind. I should relate that to my children at this point. But what the 2 points here. One was that it was so effective at getting to what she was concerned about that she felt that I had some magical powers that could address her pain, because it was all about PTSD and her ability to really regulate her response to the experience of pain in the setting of having PTSD. So she actually plugged in, thank you, did a great job with Kari. And this past week when I saw her, I said, what's the most effective aspect? And she said the CPT coach.
Yeah.
Okay, and so I wasn't sure how that differentiates from the PTSD coach and the CPT coach. So it's a good time for me to ask you that question, but also may help differentiate when we might use those in our clinical practice.
So the PTSD, it's a great question. And the PTSD Coach app is for anybody with post-traumatic stress. They can use it at any point and just explore it. I encourage you guys actually to download it yourself. If you've got a smartphone, I've got one right here. Go ahead and put it on your phone and check it out yourself. So that you're familiar. When you get into these mobile apps, more and more so over time, we expect these things to grow. You want to have some familiarity on your own, and you can say, we've endorsed it here. It's great. The VA obviously built it, endorses it, uses it, have rolled it out in their system. So that's for anybody at any time, regardless of what treatment you're doing with them. The CPT Coach app, again, is done in the context of the psychotherapy. So the patient that David's talking about, she and I are 80-90% of the way through that treatment. She's been using that app along the way and found it incredibly useful to do the homework and use the skills that we've been developing. And a lot of it is cognitive challenging skills where she's tracking negative beliefs and thoughts that are coming up for her and being able to work through them systematically and track them on her phone and measure her symptoms along the way, etc. So that app won't make as much sense to people out in the public, but I wanted you guys to know about them so you know that these are apps that we might be using if you refer people out, and also potentially ways to entice patients and say there are apps and things that can help support that kind of treatment. Find a therapist that can help you with that.
Yeah, so let me just make just a couple of comments, because I've been struck, actually I had a conversation with Dr. Sullivan earlier this morning, struck by how prevalent this is in your practice. Certainly we see pretty tough customers at the Center for Pain Relief, but we work with you in the community, and let me tell you, you're seeing really tough customers in your practice. So just don't underestimate. We did a survey using our pain tracker data 1 year. We looked at 1,200 patients, and it was so nice because we have an electronic database to do this. It took at least 12 minutes to get the entire question asked and answered. And we said, how many patients are coming, new patients to Center for Pain Relief, that's our pain clinic upstairs, with a diagnosis of depression, anxiety, and PTSD. And we saw 60% of our patients had severe depression, 45% had severe anxiety, and 38% had PTSD. It was this astonishing prevalence in the practice. So if I want to reinforce what Kari's saying, if it isn't going well, really check PTSD, because you're going to uncover that, and we've uncovered in our efforts to take patients off their high-dose opioids and their benzos, we actually unmask probably more PTSD than any condition that we've identified. So we've been suppressing the symptoms, which fit the get me out of here, give kind of, I call it sub-anesthetic doses of the drugs we use for anesthesia to get people truly out of there, put them asleep. But we've been using these treatments to suppress symptoms of PTSD, which doesn't do them any good, because the treatment is to be exposed to them and be able to experience them. So this is really an unrecognized component in the management of our patients and can be dramatically effective. All right, a couple other questions. Todd Guiton, I pronounce it French, I don't know. I'm sorry, Todd. Physician assistant, what medications would you recommend to ameliorate acute anxiety while avoiding administering benzodiazepines. Do you mind if I jump in on this?
Please.
Okay,
As
all
a
right.
non-prescriber?
Non-prescriber. Well, I know you see a lot of what we do. The first line therapy is to treat the nightmares because nightmares is a common distress. It interferes with sleep. Sleep interference produces more pain, more interference with function. So we go with prazosin. Prazosin is an anti-hypertensive drug. For those of us in the room and on the network with enough gray hair to remember, that was one of the drugs that we used to use for antihypertensive management. It was one of the cluster of 3 drugs we had back in the 80s. But we dosed it up to 20 milligrams, sometimes as high as 40 milligrams of prazosin, but recommended starting dose about 1 milligram. You can go up based on the severity of the patient's symptoms, whether they've got blood pressure issues to start with, whether on other antihypertensive drugs. Go up 1 to 2 milligrams, up to 5, can go up to 10 milligrams, and we target the symptoms of nightmare. That's what the recommendations are. The FDA has not approved it, but there is discussion in UpToDate, for instance, that it's an off-label use. I should say, incidentally, that was identified at the Seattle VA, as far as I understand it. The men who were on it for BPH, before we came out with the more targeted alpha antagonists, that was one of the drugs that was used, and they noted the vets who were on the prazosin for their BPH were having better ease of management of the PTSD. So it was one of those accidental observations. So that's first line therapy for nightmares.
I'd add to that, behaviorally speaking. So when the patients come in and they have nightmares and they're not on prazosin, I ask them to go talk to their PCPs about that. What I often see happen is when they do get that medication, sometimes it causes a little bit of orthostasis at first for the first couple of days. They need to get used to it. Sometimes they get really anxious about that, so they quit. So it's really good to kind of talk through with them that, you might have this temporary response to it. It's okay. You really will get used to that. It usually goes away within a few days. And that if you're stepping them up, that they'll notice a change in their dreams over time is what I see happen clinically. So, their nightmares de-intensify, and sometimes their dreams get weird, and then eventually, oftentimes the dreams just go away. But it takes, often kind of a titration of the dose up in their body, kind of adjusting.
Yeah, so the issue to caution, in addition to that initial side effect, is that they're going to be orthostatic if you get up high. So if you get dizzy when you stand up or you feel lightheaded, you've had enough and you may want to hold that dose or back it down. And if for any reason they're on tizanidine, the alpha-2 agent, you can augment that dizziness as well. So be cautious on the higher dose of tizanidine and then the higher doses of the tricyclics. The recommended drug for treatment of PTSD out of the pain field are SSRIs. That's the recommended drug. In the pain field, I think we would want to go to SNRIs because you want a little bit of that norepinephrine, the N in the SNRI, to get the descending modulatory systems engaged. So the SNRIs would be my current recommendation. We don't have any data yet out. I think we're ready to start breaking through in that and linking our treatment outcomes with the different drugs, and we could start to get some real published evidence of the support. And a TCA, of course, as well, but then you get into the orthostatic hypotension overlap as you go with the more noradrenergic agents with that. I language it. I'm going to get to Adrian Heath. Thank you, Adrian. You're always a regular participant, and you always have great questions, and I don't have the answer to this, but we'll read it in a second. Maybe Kari knows this. I language it. I say this is an adrenaline blocker, which is correct. It's exactly what it is, and it'll block that adrenaline surge that's driving your nightmares and is waking you up from sleep. So I use the language of sleep. I use the language of adrenaline blockade, and they really relate to that. I'll often get, yes, that's exactly how I feel. And you're onto something, and you've done that engagement because you're acknowledging how they're feeling. You're using the language of what they're feeling. You're using your medical language, which keeps it nice and medicalized because they don't want to, all of us, we don't want to believe it's a psychiatric disorder because they're experiencing pain. So you put it back in the medical context. You're helping describe the mechanism of their symptom,
and you'll get great response. I have trouble taking patients off the prazosin, frankly, because there's such a dramatic response. So, Adrian Heap, do football players with severe concussive injury to the brain manifest the same PTSD symptoms as patients with no demonstrable cerebral abnormality? And I'm going to link this, Adrian, to the traumatic brain injury question to maybe put it in what we do know. I don't think we know the answer to that. We may soon learn the answer, but you know everything about PTSD, so you teach me, Kari.
I wish.
Well, more than I do, for sure.
I can tell you, first of all, I just would tease out traumatic brain injury versus PTSD. And so, the question, lots of football players have TBIs. We know that, serial TBIs. Do they have PTSD, right? So the kind of injuries they're getting for the TBIs are not necessarily meeting that criteria A, because that has to be a horrific event, where you have intense fear, and often they're playing a game, so there isn't that. It's an accident that happens, and there isn't necessarily a big fear that might be associated. So you really need to make sure, that the injuries that they're experiencing meet a criterion A. Is there a criterion A? Is there traumatic?
Okay, so we refresh criterion A. I want you to just reinforce that, because I think we may have lost that back with all the other content.
Right, trauma, psychological trauma that meets the PTSD diagnosis has to be intense horror, fear, an intense emotional reaction. If a football player goes and gets tackled and goes unconscious, there was no experience of that horror. Just someone came from behind, knocked them down, and they went unconscious, and they now have a TBI. So there's no PTSD involved, potentially, unless there was some prior horrific emotional trauma that happened for that individual. Now, is that to say that football players don't have PTSD? No. They absolutely could have PTSD from potentially playing as well, if they were, in fact, having fear on the field. But I think, most of these professional folks, that's trained out of them in that sense.
They may have PTSD coming from the often very difficult backgrounds, at least the professionals come from.
So keep that in mind, that those things are separate. And then what I would say is that the TBI itself is another risk factor for PTSD. So, the more your brain is compromised in that way, the more vulnerable you are potentially. Now, the exact mechanisms, physiologically, there are some hypotheses out there, but they're not totally understood yet. But we do know that having a traumatic brain injury increases your risk of developing PTSD.
All right. So you once said, and I quote you on this. Let me get it right for to build on the A symptom, that the experience has to be represented as an overwhelming threat to one's integrity. Overwhelming threat to one's integrity. Am I quoting you right? Is that a fair way to look at that?
I don't remember using the word integrity, but an overwhelming threat of some kind, I think, in general. Is absolutely the case. And again, you could be witnessing it over and over and not, actually be there. So, for example, if you see your toddler almost get run over by a car, that might be horrifying to one parent, whereas another might kind of let it go. So it depends on what your own emotional response is to what you're witnessing or directly experiencing.
Okay, great. All right, Kari, thank you.